Thank you, Angie, and welcome everybody. I appreciate you taking time out of your busy schedules to join me today. So we're going to talk about neurotransmitters and how addressing imbalance can really help your patients with symptoms, some of the most common symptoms that they present with. Let's start with a definition so we're all on the same page. So we know that neurotransmitters are chemical messengers. They regulate emotional and physical processes. So things like movement, the stress response, pain, and cognition, those things come to mind. They do function in the CNS, but also in the periphery. This is important to remember. And they facilitate communication between the brain and the body's glands, organs, and muscles. They're usually considered chemical messengers between neurons. They are located at other places in the body, though, too. So, for instance, when serotonin is secreted in the gut, it's still referred to as a neurotransmitter. So, testing neurotransmitters can lead to successful treatment interventions for a variety of symptoms. This is by no means an exhaustive list. We typically think about it for mental health, but also things like chronic pain, headaches, IBS, weight issues, fatigue, cravings. There are 4 symptoms in particular that I find that patients almost ubiquitously present with, and that's mood concerns, energy concerns. They don't have enough energy or they're feeling fatigued. They're not sleeping well, and they're having trouble with focus and attention. And neurotransmitter testing allows me to feel like I have a better handle on what could be driving symptoms like those. So in the United States, antidepressants are pretty freely offered. They're sort of the best conventional approach to managing, at least in terms of medication, to manage the symptoms, depression, anxiety, cognitive concerns, et cetera. Just looking at some statistics here in terms of antidepressants, you can see that they're pretty widely utilized in the United States. You can see that about 11% of people total, this is adults, considered adults is 18 and over. You can see that women experience or utilize antidepressants about twice as often as men in those midlife years when hormones start to fluctuate. Tends to be when usage is at its highest point. Now, I want to point out here, I'm not anti-medication by any means. And so what we're going to be talking about today is largely non-pharmaceutical intervention. I'm not taking a stance on pharmaceuticals. I think sometimes they're an incredible tool. But if you're interested in trying to help patients without pharmaceuticals, if your patients aren't interested in pharmaceuticals, or maybe they're trying to wean down, or maybe they can't get in to see a provider, that's an increasingly common issue. Or maybe you just want to help support someone who's on a medication with additional non-pharmacological interventions. That's what we will be talking about today. When we think about neuroendocrine health and the neuro part in particular, where do we begin? So I like to think about trying to get down into some root causes. When we think about neuroendocrine health, we're thinking about sex hormones, adrenal hormones, and then, of course, neurotransmitters. So today's lecture focuses on neurotransmitters. I will be pulling in some information on adrenal health in particular because the stress response involves both neurotransmitters and cortisol secretion, but hormonal imbalance is also incredibly important. But of course, we have other months where we focus on that. But we do know that sex hormones are involved because we just saw on the previous slide that antidepressant use is higher among women. Doesn't mean that women are less stoic. It just means they tend to experience depression and anxiety more commonly than our male counterparts. Okay, so I screen for neurotransmitter imbalance in my practice with urinary testing. This has been commercially available in the United States for decades, but it's still a new tool to a lot of practitioners. And so I wanted to start today by talking about what a common question, and really this is a common criticism of neurotransmitter testing. People might say it's not a valid form of assessment because it doesn't reflect brain levels of neurotransmitters. And I would say that is exactly right. It does not. But let's address this question as to why we might feel that we need to discount something that doesn't solely measure what's in the CNS. I think it's a common misunderstanding that the neurotransmitters our body utilizes are solely secreted in the CNS. They're not. We know that a lot of neurotransmitters are secreted in the periphery. We know that neurotransmitters are the autonomic nervous system's chemical messengers. They're secreted both in the CNS and the periphery. The systems and the enzymes that catalyze them are the same in the brain as in the periphery. We can't measure what's in the synapse. The only way we can measure what's in the CNS is with a spinal puncture, and we know that a spinal tap is really invasive and painful, and that's not something we would do in a clinical setting. So knowing that many neurotransmitters are secreted in the periphery as well as the CNS, and that there are receptors for neurotransmitters throughout all tissues, not just the CNS, I think that we can sort of broaden our thinking to understand that while this may not be the most refined tool, it certainly is the best tool available today. I know that if I get a baseline for markers and I give interventions like the therapies we'll be talking about today, and I do a retest, I see these neurotransmitter levels change. So I find that it's a good test to give me a baseline idea of what the imbalances are for my patients. And then as I work with them with interventions, I can see some changes that typically correspond to changes in symptoms as well. And if you want to read more about this, here is some journal articles for you. Okay, so treatment concepts, that's generally why you come, right? And so I want to do a general overview of some of the treatments for neurotransmitter imbalance while our minds are fresh. Then I'm going to go through specifically each neurotransmitter on the profile and talk about how to address individual imbalances. But a lot of these are general concepts that can really be implemented even without testing. So it's important to have a understanding of what they are. But as we get started here, I just wanted to remind everybody of what the biochemistry looks like. So this is a visual of the biochemistry of these neurotransmitter pathways. This is issued with every report that you run. So it's part of the report that is given to you and to your patients. And that can be really helpful because biochemistry can be complicated for doctor and patient alike. And so this allows us to sort of visually see what the precursors to the neurotransmitters are. So you can see here the neurotransmitters are highlighted in purple text. The enzymes that move these drive these conversions are in blue, and then all of the cofactors are here in orange. So there's a key here that helps you decipher all of it. This is a really helpful tool. In fact, I typically pull it out when I'm talking to my patients about the interventions we're going to do together so they understand the why behind what they're doing. So typically after you evaluate neurotransmitter levels, you can think of targeting the imbalances with things like amino acids, cofactors that drive the enzymatic conversions, and then botanicals that can help to support all of these functions. The amino acids are the precursors to the neurotransmitters. So you can use them therapeutically. They're listed here. Some of them are actually neurotransmitters themselves, things like GABA and glycine. Generally, I recommend taking them on an empty stomach. So I consider an empty stomach to be 30 minutes before eating or about 2 hours after eating. This is, of course, individualized, but that's a good general rule. Some of them can cross the blood-brain barrier and interact with receptors in the CNS. Some of them work via vagal nerve transmission. Some of them interact with the HPA axis, but they can all have a really profound effect when we have especially lower levels of neurotransmitters when we test. Adaptogenic herbs are also often a consideration because they work to optimize HPA axis function, but they can also contribute to neurotransmitter imbalance. So these herbs help the body resist and adapt to stress. To officially be called an adaptogen, the herb has to enhance physiology without having any, considerable adverse effects. They can promote optimal hormone and catecholamine levels, whether they're low or high. They tend to have sort of a modulating effect and promote balance. And then nervines can really come in handy. These can be given in the morning or at night to restore balance to the nervous system. I think of these typically for things like stress, anxiety, insomnia, and even mild depression. There are a lot of combos available out there. Sometimes it's nice to give them in a tea. If they're in a tincture or a glycerite, you might start with droppers a couple of times a day. If sleep is the issue, nighttime dosing is better. If anxiety in the day is more of an issue, then you typically want to give it in the morning. Now, mucuna is an interesting herb. It's an Ayurvedic herb, and it's been used to treat Parkinson's in India for probably thousands of years. It contains L-dopa, levodopa, which is a precursor to dopamine. So this can be helpful when dopamine and other catecholamine levels are low. I also wanted to mention St. John's wort because it's really commonly known and it's something your patients might grab on their own. And it has been shown in a lot of studies to provide equivalent relief to mild to moderate depression when compared to SSRIs. So it's a pretty great option if mild depression, maybe moderate depression, is an issue for your patient. I do want to remind you to use it with caution only because it's metabolized via some common cytochrome pathways, and so it can interact with some common medications. And one of these is oral contraceptives, which a lot of our patients use. Now, L-theanine, this is a beautiful amino acid. It's really helpful in so many ways. It's found exclusively in the tea plant. Green tea is the best source. It can be used to treat imbalances in neurotransmission, whether you have high levels or low levels. It sort of acts as an adaptogen in that way. Some of the functions are that it can act as a GABA agonist, so that promotes relaxation and parasympathetic tone. It can have an antagonistic effect on glutamate receptors. Glutamate is excitatory, so it helps to balance that. But it can also modulate some of the neurotransmitters that we associate more with mood, attention, anxiety, things like that. L-theanine has a pretty broad therapeutic window, so you might consider doses of 100 once a day up to maybe 500 once or twice a day. It has a lower half-life, so twice a day dosing is often something to consider. But it can help not only with feelings of anxiety and irritability and agitation, but it can actually also help with cognition, especially in its native form, which combines a little bit of caffeine with the L-theanine. It increases focus and attention in a gentle way, something that's been called mindful alertness. And meditation, we don't all do it. We probably all should. Regular meditation has been associated with higher levels of serotonin and lower norepinephrine levels. Dopamine has been shown to be increased in meditation. It can increase GABA levels and even melatonin levels at nighttime if we meditate during the day. Okay, we're going to dive in and get a little more specific now by focusing on cofactors. So remember our biochemistry here. The cofactors are listed next to the enzyme that they help promote. And the cofactors are essentially the gas in the engine that is the enzyme. These are necessary in order for the enzyme to work properly. So they become important clinically if you see that a conversion is slow. So let's take an example here. If norepinephrine were found to be elevated, but epinephrine levels were low, that would mean that this PNMT enzyme was probably sluggish. Well, what fuels that enzyme? Cortisol. So you might want to look into HPA axis health. Is cortisol suboptimal? And it's a methyltransferase. It's methyl dependent. SAMe is a methyl donor. That means you want to make sure your patient is methylating efficiently to make this conversion work appropriately. Some pearls about cofactors. Using activated forms is really important because if your patient is unable to efficiently activate these forms, then it can slow down the efficacy of the treatment. So use activated forms like vitamin B6 in the form of pyridoxal 5-phosphate, the methylated forms of folate and B12. B2 would be riboflavin 5-phosphate. You get the idea. But methylation in particular is important here. Probably going to be an important part of your treatment plan, but especially if your patient has an issue with methylation. We know that methyl tetrahydrofolate reductase is the name of both the gene and the enzyme that helps us process folate. And if it's interrupted, we see so many problems system-wide, but in neurotransmission, what we see is often a decrease in the amount of neurotransmitters that are being made. So again, we have 5-MTHF. That is the critical cofactor for neurotransmitter synthesis, and also just antidepressant activity. So if you suspect that your patient potentially has a problem with methylation, there are a couple tests available through doctor's data. On the left, you can see our DNA methylation test. This is a DNA test, so it's a buccal swab. So it identifies various SNPs that could predispose your patient to methylation issues. On the right, you can see here, this is actually our plasma methylation test. This is more of a functional test. So it measures a patient's current methylation capacity. And it's truly the best option for monitoring and guiding therapeutic interventions. So in April, there's going to be a Wellness Wednesday lecture devoted to methylation testing. Please join us if you want to learn more about this. But in terms of methyl support for neurotransmitter synthesis and secretion, you can choose some therapies like you see here. Essentially, we want to try to provide the methyl groups that the body is struggling to make. All of these neurotransmitters require methylation to be made. You'll sometimes see the word monoamines used to say which neurotransmitters are methyl dependent. Monoamines refers to serotonin and the catecholamines, so just a reminder there. And the reason I put epinephrine in italics is because I've seen a lot of reports now where we know the patient has an established methyl defect, and serotonin, dopamine, norepinephrine, glycine may be low, but epinephrine isn't, which can be confusing if you're new at this. But I think it's because epinephrine is so crucial to the stress response that the body sort of prioritizes which pathways will get the available methyl. But certainly if you see low to low range levels in some or most of these, I would suspect a methyl defect with your patient, and you may want to investigate that further and or provide empirical support. Vitamin D is another important cofactor. It activates gene expression of both the tryptophan hydroxylase and the tyrosine hydroxylase pathways. This is one proposed hypothesis behind seasonal affective disorder, because in the winter months when we don't get exposed to sunlight as much, and if we're not supplementing, then we can have vitamin D deficiencies. And so these enzymes that make serotonin and dopamine for us tend to work less efficiently. Fish oil is also really important. It's not a cofactor, but it does benefit the nervous system. So there's two major components in fish oil, EPA and DHA. EPA is the anti-inflammatory component, and DHA provides fluidity to cell membranes, and it's vital to brain and nervous system function. And additionally, inflammation often underlies chronic health issues, and depression and anxiety are, included in that. So just for the antidepressant effects alone, minus the mechanism, fish oil has been shown to be really beneficial for patients. We also need to consider the microbiome. There have been studies in the last couple of decades that have demonstrated a bidirectional relationship between the gut microbiome and brain function. By now, you likely know this. We call this the microbiota gut-brain axis. So this is this emerging concept that suggests that modulating the gut microbiota may be a strategy for developing therapeutics. Some nutritional tools that we have in that realm are, changing diet to focus more on soluble fiber, which our microbiome needs. That's its primary fuel source. Prebiotics, which again is sort of giving supplemental fuel, supplemental soluble fiber, or giving probiotics on their own. This was a study that looked at a particular strain of lactobacillus and bifidobacterium in rats and humans. So the evidence suggests that probiotics can improve mood and psychological distress, and the authors proposed 3 potential mechanisms. One is that these good bacterium can competitively exclude the bad ones. Also, they may decrease the pro-inflammatory cytokines that can come from dysbiosis, but also there may be direct communication with the CNS via the vagal nerve. This is more and more understood to be a really important pathway between the gut and the brain, is that traveling up and down the vagus nerve. So all of these are proposed mechanisms as to why making sure your patient has a healthy microbiome is really essential to having good neurotransmission. There are ways to actually determine the makeup of the microbiome with PCR testing, and the GI360 profile by Doctor's Data does that. So here's an example of the first page, and you can see that we give information on sort of the phyla here and how your patient's imbalances. Your patient is this webbing and how they look compared to a normobiotic population, which is identified here by this green area. And we're giving you a dysbiosis index and a diversity score. So we want to have low dysbiosis, but good diversity. So this is an example of a microbiome that could potentially predispose a patient to having neurotransmitter imbalance. And if you want to read more, there you go. Okay, I mentioned inflammation. Let's return to it. Not every depressed person is inflamed, but inflammation is a very common avenue to depression, and you need to consider it when you're trying to determine the root cause of issues for your patients. So on the left here, you can see some common things that can contribute to inflammation. Obesity, being sedentary, not sleeping well, adverse childhood experiences, et cetera, et cetera, et cetera. Whatever is driving the inflammation, we got to find it and try to manage it, because inflammation will hijack neurotransmission. There are a lot of mechanisms here. Some of them in the blue boxes here are proposed mechanisms, but what we end up with is anxiety, depression, other psychiatric disorders, because the inflammation is driving neurotransmitter imbalance. The inflammatory cytokines can actually cross the blood-brain barrier, and once they reach the brain, they can influence the synthesis, release, and reuptake of neurotransmitters like serotonin, dopamine, and norepinephrine. And more research supports the idea that depression, while it is a disease unto itself, may actually be a symptom of inflammation. Inflammation affects neurotransmitter metabolism, neuroendocrine function, and neural plasticity. Now, this paper is great. I love the title of this paper. It's called, So Depression is an Inflammatory Disease, but Where Does the Inflammation Come From? And you can see the authors state a lot of places, but systemic inflammation is very important. And we need to consider psychosocial stressors, poor diet, physical inactivity, obesity, smoking, altered gut permeability, atopy, dental caries, sleep, and vitamin D deficiency. So I've actually started, I now have a little Post-it note, and I ask about these specific sources of inflammation, because I've just found that it's a great starting place for me when I'm sitting down with my patient to try to identify where the inflammation may be coming from. This is taken from an article in Psychiatric Times from 2018, but they list some helpful considerations when treating mental health, including assessing for a common cause, which is inflammation. So they recommend not considering SSRIs as a first-line therapy. So maybe to start with addressing nutrition, lifestyle, trying to manage some of the basic pillars of health that can lead to inflammation. So some of those are listed here, but you can see that essentially treatment for patients with multiple inflammatory risk factors is a really important part of treating these patients. So if you want to look at your patient's neurotransmitter imbalance, there are two profiles offered by Doctors Data. We're going to start with the NeuroBasic profile. You can see here tests for serotonin, dopamine, norepinephrine, epinephrine, GABA, glutamate, glycine, histamine, and phenethylamine. And to orient you to our reference ranges here, blue is frankly low, red is elevated, and then everything between the yellows and the green, this is considered within the reference interval. But if your patients are trending low or trending high, it's marked in yellow, because typically we do like to pay attention as functional docs as things are moving, towards one extreme or the other. So now I'm going to go through that profile neurotransmitter by neurotransmitter. And we'll start with serotonin. Arguably the star of the show has been ever since SSRIs came onto the scene, the end of the 20th century. Serotonin is biochemically derived from the amino acid tryptophan, and it's actually primarily secreted in the GI tract. Up to 90% of the serotonin we make is secreted in the gut. The platelets in the CNS secrete the remaining 10 to 20%. Now, here's a list of some, but not all, of the symptoms you might expect to see with imbalanced serotonin. So some of the physical changes might be fluctuating body temperature. The hot flashes that women and even men experience in midlife are associated with serotonin. Aches and pains, and even bowel and bladder issues. Remember, because serotonin is secreted so much in the GI, serotonin imbalance can be associated with GI issues. But also the mood concerns, those typically come to mind. First of all, poor sleep, because serotonin is a precursor to melatonin. You can see some of the things here. So it's not necessarily a goal to try to make your patient's serotonin be as high as it possibly can be. We can see symptoms like this if serotonin is too low or if it's too high. So the reference ranges are there for a reason. We want to typically try to, with therapy, whether it's medication or nutraceuticals or diet or lifestyle, we're trying to move patients more into what's considered to be the reference interval for a healthy person, meaning a disease-free person. Some patients might feel better at the top end of that or the middle, but generally we're not just trying to boost serotonin through the roof. Just keep that in mind, because high serotonin can also be a problem. As we move through the various neurotransmitters, you'll also likely notice that a lot of the symptoms you're seeing here with serotonin are going to come up again and again. You're going to see mood concerns associated with many different neurotransmitter imbalances. You're going to see cognitive concerns come up again and again. This is one reason why I have come to rely on testing, because I can't always tell just by looking at my patient and hearing their symptoms which neurotransmitter is driving the issue. Appetite change is commonly seen with imbalanced serotonin levels. This might look like a lack of interest in eating, but more commonly what we see is cravings for usually sweet foods or simple carbohydrates. This seems to be an attempt at self-medication, because if we eat these foods, we might have a brief increase in serotonin as a result of them. That feels good because we're typically lower in serotonin. So this is sort of a self-medicating behavior. Often neurotransmitter imbalances will drive the behaviors that we're seeing in our patients. So I'm going to walk you through the treatment slide for serotonin, just again to orient you, and for the other neurotransmitters, I won't do it so specifically. But you can see here we've taken a snippet from our biochemistry. So the amino acid precursor tryptophan is here. You can see it moves through 5-HTP into serotonin. It is metabolized via the MAO enzyme into its metabolite 5-HIAA. You can also see here if we move down from serotonin, eventually we reach melatonin. So how would we support serotonin if values are low? Well, typically with the precursors like tryptophan or 5-HTP, low potency rhodiola. Melatonin, interestingly, is now we understand a treatment for low serotonin. This is actually a bidirectional movement, but we'll get into that. The L-theanine, I mentioned that as being sort of adaptogenic, so it can help modulate levels, whether they're too low or too high. And then any cofactors that help fuel the enzymes that make serotonin. So P5P, that's vitamin B6, iron, BH4 tetrahydrobiopterin, that is methyl dependent. So essentially that's a methyl donor. Vitamin D, these are all important cofactors here. Again, P5P comes up. And for metabolism, other B vitamins and iron. B vitamins, super, super important in all these pathways. What if our serotonin is too high when we test our patient? Well, here we might think again about theanine. It modulates. High potency rhodiola can suppress levels that are too high. Low potency rhodiola can boost. Very high potency rhodiola could help to modulate levels and bring them back down. And again, cofactors to support metabolism and conversion if that's what's necessary. So that is what these treatment slides are telling you. So again, that idea that melatonin could actually boost serotonin, this we've learned is a bidirectional relationship. So if your patients are using a lot of melatonin to help them sleep, and then you don't have them take a break from that when they're testing neurotransmitters, and that's not necessary, you just need to know that the melatonin could be contributing to any serotonin levels that are found on testing. All right, moving on to dopamine. People with extroverted personality types tend to show higher levels of dopamine activity than people who are introverts. This neurotransmitter stimulates the reward and pleasure centers in the brain. It also affects movement and behavior. So if we think about that from an evolutionary standpoint, we can move towards the reward, right? That's what dopamine is helping us do. The reward response with dopamine is enhanced, especially if the reward you get is greater than what you expected. So I like to use this example with my patients. Remember being a child, standing in front of a gumball machine with the big shiny gumballs, and you ask your mom or dad for a quarter. You put a quarter in the machine and turn the crank, hold out your hand, and if one gumball drops in it, that's great. But if you ever had the experience of having two gumballs drop in your hand with one quarter, Do you remember the excitement that you felt at that unexpected windfall? That's dopamine, because getting 2 gumballs for the price of 1 was more than you expected. That's the dopamine feeling. Dopamine is a catecholamine. It's derived from the amino acid tyrosine, and it converts through L-DOPA into dopamine and then onto norepinephrine and epinephrine. And for our friends who don't live in the United States, these are also known as noradrenaline and adrenaline. So this is how people with excess dopamine may see the world. Things that once seemed safe no longer do. You might see symptoms like worry and paranoia, maybe ADHD, a decreased ability to interact socially, and a desire for instant gratification. Dopamine deficiency may look more like mood swings, depression, anxiety, isolation, loss of interest, issues with motivation, right? Again, we come back to motivation. So people may have trouble finishing tasks. It may manifest as a drop in sex drive. Low dopamine can result in forgetfulness and then other pathological states, right? So Parkinson's is the most well understood, but even schizophrenia, autism, ADHD, and restless legs have been associated in some of the literature with dopamine deficiency. Interestingly, people with low dopamine activity may be more prone to addiction. And this is things like food, drugs, sex, gambling, because again, if dopamine is low, we may participate in behaviors that result in dopamine secretion so that we feel good for a moment, and then the dopamine levels go down again. Dopamine is sometimes called the motivation molecule. Lab mice that are dopamine deficient are so apathetic, they will literally starve themselves to death, even when food is readily available. That's how important dopamine is to motivation. So here's some options to support dopamine. So now I'll let you look at these on your own time. Massages, not just good for the back. They've also been shown to influence cortisol secretion as well as serotonin and dopamine secretion. Dopamine converts downstream into norepinephrine and epinephrine. So you can see we've added a hydroxyl group here and then a methyl group here. They work together to control the fight or flight response, attention and arousal, and then regulate things like heart rate and blood sugar, and also release glucose from energy stores. Norepinephrine is released during stress. It stimulates the fight or flight response. Most of the norepinephrine we secrete is secreted in the CNS from the locus coeruleus, and here's a little slide of that area of the brain, but it is also released in the periphery from the adrenal medulla. But the epinephrine that we experience is part, or the increase we experience is part of the stress response. This happens solely in the periphery. So it's synthesized in the adrenal medulla. So the cortex is where we get cortisol, and then the medulla is where we get epinephrine. And it helps us respond to stress. So it works with norepinephrine and cortisol to coordinate this fight or flight response. And the fight or flight response is really evolutionarily created to allow us to flee danger. So it involves glucose and glycogen metabolism. So we need to essentially give our cells more fuel so that we can flee the danger. So what do these people have in common? With all these people doing these extreme sports, what do they have in common? We might call them adrenaline junkies. So just like with low serotonin, people may reach for carbohydrates, or with dopamine, that people may engage in risky behaviors like, gambling, food, overeating, that sort of thing. When catecholamine levels are low, some people engage in this type of self-medication behavior, right? They're self-inducing a fight or flight response by intentionally engaging in these risky behaviors because they get a release of epinephrine and a release of adrenaline. It gives them sort of a temporary high. Now, I just want to note, it's great when people love extreme sports. This is not some sort of a position statement on extreme sports. But if you have patients who come to you and say, you know what, I really don't feel alive unless I'm engaging in this type of activity, that might be a time when you would consider that it's time to sort of work them up and see if there's some interventions, because none of us want to be attached to behaviors because they're the only time we feel something, the only time we feel alive. Because catecholamines are excitatory, if we have low levels, you might see symptoms that are more reflective of sort of a dampened affect. So poor attention and memory, decreased concentration, brain fog, reduced socialization, loss of alertness, depression, pain, lack of arousal, lack of interest. Conversely, because they're excitatory, if we have excess levels of catecholamines, you could see physical symptoms like palpitations, tachycardia, arrhythmia, restlessness, hypertension, or on the mood side, irritability, anxiety, agitation, sleeplessness, not being able to relax, not being able to focus. So sort of an easy way to put it is that these people are overstimulated. So treatment ideas for supporting norepinephrine and epinephrine. Now, I want to talk about the norepinephrine to epinephrine ratio, which is calculated for you on the reports. What this is doing is examining the conversion between norepinephrine and epinephrine and giving you a ratio between the two. So if the norepinephrine is not converting efficiently into epinephrine, we'll have a high ratio. This generally is a clue to you to work them up for HPA axis health, because if they don't have enough cortisol, this is not going to work well. Because both cortisol and the catecholamines are involved in the stress response. So let's talk through the stress response. So we know that the first stage, and this is sort of my categorization of these things. I think about there being sort of three phases of the stress response. Phase 1, phase 2, phase 3, or early, mid, and late. So you could have patients who are presenting to you with the same types of symptoms. They're fatigued, they're depressed, they're anxious, they can't focus, they can't sleep. Pretty common presentation, right? But patients experiencing these same symptoms can be at different phases of the stress response. And depending on the stage of the stress response that you find them in, it can really affect the treatments you choose quite a bit. So here's an example of the early stage of the stress response. So typically in the early stages, we'll have higher cortisol levels and higher levels of norepinephrine and epinephrine being secreted. At this point, the body is still very efficient at responding to stress, but the sympathetic nervous system is not designed to stay in high stress mode continuously for months and months and months. At this point, we start to see some HPA axis dysfunction and some changes in neurotransmission. Some people might call this adrenal fatigue, but the adrenal gland isn't actually fatiguing. It's the sympathetic response and the HPA axis that are adapting to a constant onslaught of stressful stimuli. So when you test people at this point, sometimes you'll see things high and sometimes you'll see things low. Generally, we'll start to see cortisol levels start to slip, and then changes in norepinephrine and epinephrine. I will say that I typically see epinephrine holding on the longest because it's so imperative to the stress response. We have to be able to flee danger. And so the body will prioritize epinephrine, but we will typically start to see some levels start to slip. And then, of course, patients without help will sometimes find themselves here in this late stage or phase 3. At this point, they're pretty depleted. They're probably pretty exhausted. So even though the symptoms they're reporting are the same, anxiety, poor sleep, can't focus, etc., these people probably feel pretty lousy. And all the markers we see here are low. Cortisol's low, epinephrine, norepinephrine, low. Now, I just want to point out here, we still have an elevated ratio, but because both of these values are low, it's less important. If you see if the ratio is elevated when we were secreting more appropriate amounts of these catecholamines, it's really important to consider cortisol. When we've got low levels like this, the ratio is less important, but of course, cortisol is likely playing a role, as well as the depletion we see just from enduring stress for weeks, months, years in some case. So there are really no hard and fast rules here, but these stages, I think, reflect some of the dynamic changes we can see when people are faced with chronic stressors. So you can combine salivary cortisol testing and urinary neurotransmitter testing in one kit with our neuroadrenal profile. We try to make that easy for you. Okay, moving on. Glutamate is the most abundant excitatory neurotransmitter in the body. It's molecularly similar to GABA. See, it's first cousins here, but they actually have opposing neurological effects. So glutamate is our primary excitatory neurotransmitter, and GABA is our primary inhibitory neurotransmitter. Glutamate is excitatory, so pathologies that correlate to high levels are things like anxiety or insomnia or issues with concentration, whereas if it's low, we're lacking that excitation, so we might see depression, fatigue, brain fog, addiction dependency, or slowed learning. To support glutamate, we have some ideas here. And for GABA, again, the main inhibitory neurotransmitter, that means it's relaxing and calming. GABA A is the predominant receptor, and GABA A receptors are utilized by drugs like benzodiazepines, which are often prescribed for anxiety, for seizure disorders, or even as just sedatives or muscle relaxants. So if someone is using medication like that, you'd want to use GABA with caution because you don't want to overdo it when it comes to these inhibitory effects. So low GABA levels are typically found in panic, anxiety, and depression-like states because it's inhibitory. So if you don't have enough of it, patients may feel excitatory, stimulated. And so conversely, if we have too much GABA, we might see that dampening affect, drowsiness, difficulty concentrating, diminished memory, etc. I do want to point out, though, that GABA can sometimes be seen on reports as elevated when you've got a lot of excitatory secretion elsewhere with excitatory neurotransmitters, so glutamate, dopamine, epinephrine, et cetera, because the body is trying to bring balance. The body is always striving for homeostasis. So sometimes you'll see elevated GABA without supplementation because the body is increasing it as a way to try to keep that balance. And here's some ideas for addressing imbalanced GABA. Histamine is excitatory as well. I think of it primarily for issues with sleep-wake cycling, but it's also involved in inflammation, of course, because it has a dual role. It's both a neurotransmitter and it's an immunomodulator. But when it comes to sleep-wake regulation, it increases wakefulness, right? So the way I'll often explain this to my patients is think about taking an older antihistamine like Benadryl. It crosses the blood-brain barrier and it makes you feel drowsy. The newer antihistamines, the newer generation, are designed not to cross the blood-brain barrier, and typically patients can take them without feeling drowsy. So we can also work in a similar way to decrease histamine levels with more natural approaches, or we can try to increase histamine if it's low with some strategies like, that's our next slide. Quickly, symptoms associated with imbalanced histamine. If it's low, we may see drowsiness, issues with digestion and appetite, and learning, memory, and mood. So histamine is involved in digestion. It's involved in that immunoresponse with mast cell degradation, and then also as a neurotransmitter. And if it's high, again, we can see wakefulness and insomnia because it interrupts that circadian rhythm and can keep people from falling asleep. You may also see allergy-like symptoms and GI concerns, again, because of the many roles that histamine plays. But supporting low and high levels, you can see ideas here. Now, some foods contain histamine, and so looking at the diet is typically an important step if your patient is testing with high histamine, or you can also give the enzyme diamine oxidase with food to help them digest these foods if they're having trouble avoiding them, or maybe they're culturally important and they just don't want to stop them, for reasons like that. Now, glycine is the second most widespread amino acid in the body, and it also acts as a neurotransmitter. It's made in the liver, mostly from serine, and in humans, it's found in high concentrations in skin, the connective tissues, and the muscles, and within the CNS, it's primarily found in the spinal column. It's inhibitory. It can help the body regulate temperature during sleep. This is why you may be familiar with giving it to peri and menopausal women who are having night flashes. But it's also a building block of protein. So if levels are low, Sometimes you'll give bone broth because it contains, the collagen and the things from the bones. But I'm getting ahead of myself again. If glycine is low, we might see poor sleep, poor cognition, and issues with memory. And if it's high, again, maybe compromised cognitive processing. So again, we're seeing this cognition piece come up again and again, as well as the mood stuff. This is why it's so tricky to choose correct therapies based only on symptoms. But again, to support glycine, you can see some ideas here. But again, bone broth, because we're boiling the bones and the connective tissues long enough to extract the glycine, that can be a treatment if glycine levels are low. Conversely, if you test a patient and they've got high glycine, you want to ask them about diet. Are they eating a lot of gelatins or foods that may have glycine in them? Phenethylamine, more commonly called PEA, is excitatory. We know low levels are associated with things like ADHD. In fact, some research indicates it could be thought of to be a biomarker for ADHD, and we'll look at some studies on the next page. If it's too high because it is excitatory, then you can see those typical excitatory symptoms: anxiety, nervousness, etc. So 3 studies have confirmed that urinary PEA levels were found to be significantly lower in patients who had ADHD, and that these levels are normalized when they were treated. Now, in this research, they were often treated with stimulant medications like Ritalin and Adderall, and those medications raised PEA levels. It is also possible to do it without pharmaceuticals. But this is some of the research that has suggested that if you identify low PEA in a patient, it is a very strong correlation with ADHD. So if you wanted to try to support PEA without meds, you could consider the precursor phenylalanine, which is sort of that precursor before tyrosine and the catecholamine pathway, but you see PEA comes down here off the bottom. Now, do be aware that there's a common supplement out there that's given for pain that's also called PEA, but that's this compound, not phenethylamine. So just read your labels carefully if you're trying to support PEA in a patient. And some resources if you wanted to read more about the supplementation suggestions. So when you're looking at these reports, looking at the absolute value of the different neurotransmitters, that's really important. But a secondary consideration is how much excitatory activity is there in comparison to inhibitory activity. So the neurotransmitters that are considered to be excitatory are glutamate, dopamine, norepinephrine, epinephrine, histamine, and PEA. The inhibitory ones are GABA, glycine, and taurine. Serotonin I list here sort of a little bit on its own. I don't consider serotonin to necessarily be inhibitory, but it's certainly not excitatory, and it does help your body secrete melatonin, so you keep that in mind. So now let's move on to metabolism. So in our biochemical pathways, these little arms here, monoamine oxidase and catechol-O-methyltransferase, are showing you movement to the various metabolites. Our comprehensive neurotransmitter profile is our larger profile. So in addition to the neurotransmitters that are offered on the basic test, you can also see metabolites as well as some trace amines and some other markers. But the metabolites really are where the rubber meets the road here. Being able to monitor not only what we're secreting, but how we're metabolizing levels gives us the best insight into why our patient may be experiencing some imbalances. So monoamine oxidase, MAO, helps to break down all of the monoamines. So remember, the monoamines are serotonin as well as the catecholamines. So MAO is all that's needed to break down serotonin, and then it works in concert with COMT to help break down the catecholamines. We can have genetic variants, though, in these enzymes. And so if you're, whatever the SNP is results in slower MAO function, we'll often see higher levels of neurotransmitters. If whatever the SNP is results in faster activity, then that could deplete the neurotransmitters. So on the report, MAO activity affects all the markers that you see here, DOPAC in this example, not 3-MT, but you can see what's leading there. So to support MAO, if it's sluggish, we're typically thinking about B vitamins again. I would never address neurotransmitter imbalance without including a B complex. Iron is important, but really only if the patient is iron deficient. So you want to check that first. And then avoiding things which could inhibit the monoamine oxidase enzyme. And on the next slide, I give you a more exhaustive list, but tobacco and caffeine are the ones that are more commonly consumed by people in our society. If MAO is overactive, it creates a lot of antioxidants. It's a oxidase reaction. So you could think about antioxidants. Sorry, it creates oxidation. So we can think about antioxidants to help address that. And then St. John's wort, the proposed mechanism of action is that it acts as a monoamine oxidase inhibitor, which would increase the amount of MAO that we have. So we could slow the activity. Sorry, I said that wrong. It can slow the activity of the monoamine oxidase enzyme, which gives us more serotonin to work with because we're not metabolizing it as quickly. And here are some of the other MAO inhibitors. You can see the list here is pretty long, but again, tobacco and caffeine are the ones that our patients might be getting into on their own more commonly. So when we think about metabolizing the catecholamines, we need to think about catech-O-methyltransferase. So there's some pharmaceutical COMT inhibitors that have been developed for things like Parkinson's disease, where we want to try to make sure patients have access to dopamine for longer. But I want to show you here, this is how we need both MAO and COMT to break down the catecholamines. So here we have dopamine. If MAO is the first step, we end up with this intermediary DOPAC. Then COMT works on it to create homovanillic acid. Alternatively, if the COMT acts first, we have this intermediate 3-MT, and then MAO turns it into HVA. So some other labs may report HVA or VMA. Those are just different markers showing you different enzyme activity. So make sure if you're monitoring HVA or VMA that you're understanding which of the enzymes is driving it, because that will help determine what therapies you choose. So again, COMT variants are pretty common. There's one review that suggests up to 80% of the population may have at least one SNP in the COMT gene. So anything that would slow activity will result in having more catecholamines. So higher dopamine, higher epinephrine, higher norepinephrine. But if it's a fast activity, then it would potentially deplete the neurotransmitters. So the people who, have lower levels of neurotransmitters, generally, these are the symptoms we'd be thinking about. Whereas if they've got higher values, that might be lower stress resiliency, that stress response. There's so much epi and norepi around that they're sort of living in that stress response, maybe hyperreactive type people. So on the report, COMT affects 3-MT, norepinephrine, and metanephrine. So these three values, when reported, reflect the activity of the COMT enzyme. Here are some ideas for supporting COMT if it's sluggish or if it's overactive. Now, why would we support the MAO enzyme if it's overactive? Well, remember, catecholamine metabolism is a two-step process, also requiring MOA. So MAO. So we want to make sure that we're supporting both of those enzymes in this pathway. But there are other things that I haven't talked about yet that can influence neurotransmitter levels. And so because we're short on time today, I just wanted to sort of touch on them. But we know that diet affects everything. Of course, you are what you eat. When it comes to neurotransmitter secretion and metabolism, it's essentially a Mediterranean diet. We're back to sort of the core tenets of a good diet. We want to make sure that we're getting just high quality fruits, veggies, oils, and proteins. Some people ask me, can I address my patient's neurotransmitter imbalances with diet alone? And my answer is theoretically yes. But as you all know, when we're working in clinical practice, the lives of our patients and their physiology and their biochemistry, it's pretty complex, right? So, none of us live in a vacuum where we can perfect someone's stress and diet and exercise and sleep and all that stuff. So as a general rule, most Americans eat enough protein. So unless you're dealing with a poorly practicing vegan or vegetarian who might be protein deprived, most of us eat enough protein-rich foods to supply amino acid precursors to all of the neurotransmitters, but we can still see imbalances. So the issue doesn't seem to be a lack of amino acids, but are they being absorbed and how are they being utilized? So you might consider GI testing if you feel like the patient's eating really well, but you still see imbalances. So what else could be going on? Avoiding gluten is a bummer, but it could be really important here because the hybridization and deamination of wheat appears to be playing a role in the increase in gluten sensitivity and celiac disease, but also inflammation, degeneration, and even autoimmunity. And so there's some studies out there that indicate that gluten sensitivity, whether it's celiac or just an enteropathy, actually can destroy brain and nervous tissue more than other tissues, more even than the GI tract. So if you've got issues in this area, I highly suggest that you have your patient avoid gluten, at least for a period of time, because it can be so damaging to nervous tissue. Now, hormones are so important here. Estradiol can increase serotonin and dopamine synthesis and decrease its breakdown. In males, it's primarily testosterone that affects serotonin and dopamine. And we also need appropriate amounts of thyroid hormones. But when we think about estradiol and testosterone, but estradiol in particular, when estradiol is low or variable, high, low, right? It's changing a lot, like we might see in puberty or perimenopause, or then maybe frankly low, like we might see in menopause. We get a lot of symptoms. So this probably helps to explain why women report more mood changes during times of hormonal shifts, like puberty, like PMS, like perimenopause. Males are also vulnerable to these shifts. It's just that the cyclic nature of women's hormones is more frequent, right? Month after month after month. So very likely contributing to the symptoms we see during these times, things like anxiety and depression. So working to balance hormone secretion is really a crucial part of any treatment plan, especially during these times of fluctuation and change. We don't have time to dive into that in today's lecture, but it's really important. And as you know, we talk about hormones in a lot of these Wellness Wednesday lectures. Okay, so now I'm going to quickly do some common FAQs before we wind up for the day. So, sometimes we're asked which profile is more appropriate. Should I run the NeuroBasic or should I run the more comprehensive profile? So both are great tools of evaluation. If you're new to the game, I suggest starting with the NeuroBasic till you feel more comfortable with some of these basic treatment approaches, how to read the reports, et cetera. If you have really complicated patients, though, you might consider the comprehensive profile so that you can monitor the metabolites, because then we can see how are these being secreted, but also is the way they're being metabolized affecting the amount of neurotransmitter that we're seeing. And also, if you have patients who have an MTHFR defect, or they have a COMT or MAO defect, you're going to want to do the more comprehensive profile, so that we can see how they are metabolizing, how they are methylating, et cetera. Remember, DNA is not destiny. So we want to test so we can see how is this genetic issue affecting physiologically what's going on with my patient. Okay, so there's two options for collecting urine, a 24-hour collection and a spot collection. The 24-hour collection gives you an average of neurotransmitter excretion and secretion throughout the day. So it will reflect any food that your patient is eating and any stress that they find themselves in over the course of the day. It is the only option if you have a patient with kidney disease, because we can't, creatinine levels are difficult to calculate in kidney disease. So 24-hour is necessary then. But in general, if your patient has healthy kidneys, I recommend doing the spot, only because the 24-hour collection is so cumbersome. You have to carry around this big jug, and you have to collect every single void, because if we miss even one, then you're not going to get the right information from the test. So it's cumbersome. The spot is great because then we don't have to worry about that 24-hour collection. It also doesn't take into account the environmental influences. So it's really more of like a basal test. What do these neurotransmitters look like without coffee, without traffic, without fighting with my spouse? You can do either a first or a second AM void. And next slide will go into that more, but the levels correlate really well with the 24-hour results. So should you do first or second void? A second void used to be industry standard. And so if that's what you're comfortable doing, you're welcome to continue to do second void. But I typically recommend first void. So that means the patient just gets up and first thing in the morning, right out of bed, they'll collect that urine and send it in. Compliance is great with that one. And it includes neurotransmitters that have pooled throughout the night. So if your patient has had issues with anxiety, that's kept them from sleeping, or pain that's kept them from sleeping, or whatever the case may be, then it will be reflected in that morning sample and give you some good information to go on. If you do decide to go with the second AM void, you want to not have patients take meds or foods or caffeine before they collect. A really common question we get is, what about my patients who are already taking psychotropic medications? How do they need to stop them to test? How will it affect the test results? So the answer is you can test patients who are using these drugs. We don't want you to stop any prescribed medication just for the purposes of testing. You know, patients often rely on these to feel well. We don't want to withdraw it quickly just for the purposes of testing. But then you have to look at the patient's report through the lens of what the effect of that medication would have on the reported values. Most of the time, patients aren't tested before they're put on something like an SSRI, so we don't necessarily know before or after. But if a person is on a serotonin reuptake inhibitor and we're seeing issues with serotonin, we know that that medication could be contributing to that imbalance. You just keep that in mind. We do know that long-term SSRI use seems to deplete serotonin levels. So it's a misnomer that SSRIs are boosting serotonin. They're not necessarily boosting serotonin secretion. What they're doing is making sure that your body has more of an opportunity to utilize the serotonin that it is making. And so because we're keeping it in the synapse for longer by inhibiting the reuptake, we actually probably deplete it faster than we might otherwise, just because we're using it more. So I tend to see lower levels of serotonin on patients who have been on SSRIs for a longer time. That's not always true. Again, every patient is an individual and metabolizes things differently and that sort of thing. But don't be surprised if you have a patient who's been on an SSRI for a longer period of time, and this is probably years, may have lower serotonin. Fresh use, if they're on something newer, you may see higher levels. So it's sort of an unknown, but you certainly don't have to avoid testing if a patient is on a psychotropic med. You can test them to see what the current imbalances are while they're using it, and then you can support them around the med. And if they want to withdraw the med, then you know better how to support them in order to wean them down. Okay, so in summary, our patients are very complex. We know this. And we know that similar symptoms can be the result of many different and individualized neurotransmitter imbalances, as well as hormone imbalances. But in this case, we're talking about neurotransmission. And so if we're able to test, then we can get information on what a patient's particular imbalances are, so we can choose really targeted therapeutics for our patients. It really helps us understand the physiology of our individual and choose, specific treatments for them. Okay, thanks everyone for your attention.